Yeah. Inas will continue the class on esophagus. The I think it was caustic strictures of esophagus and things like that. Now is going to talk about perforation and complete the topic. Okay, Inas.
Yes, sir. Uh, so, in esophageal perforation, uh, uh, esophageal perforation is a diagnostic and therapeutic challenge because it is a rare condition, and the presentation can be quite variable. In terms of the anatomy, the esophagus has three anatomic points of narrowing. That is the pharyngeus muscle, the bronchoaortic constriction, and the esophagogastric junction. Perforation may occur anywhere along the esophagus, but uh, like there is a possibility for rupture, which is higher at these key anatomic areas. For example, iatrogenic injuries to the cervical esophagus can occur during endoscopy because these areas are lacking posterior esophageal muscularis. And again, it's a very narrow area which is bordered by the cricopharyngeus muscle inferiorly and the inferior constrictor muscles superiorly. Um, in the etiology, usually increased intraluminal pressure at the anatomical sites of narrowing, uh, as well as if the site is narrowed by a malignancy, foreign body, or physiological dysfunction, can lead to rupture of the esophagus. More than one half of all of the esophageal perforations that occur are iatrogenic, and most of these occur during endoscopy. And this can be during the procedure of endoscopic procedures like dilatation as well. Other causes of esophageal perforation includes spontaneous perforation, that is the Boerhaave syndrome, which accounts for around 15% of the total incidence. Foreign body ingestion, which accounts for around 12%, wherein the impacted foreign body can erode the esophageal wall. Trauma, which is seen in 9% of the cases, which is because of any external leg or chest trauma or any penetrating injury. And uh, malignancy, that is the tumor eroding through the esophageal wall, accounts to 1 to 5% of the total incidence of esophageal perforation. And the clinical presentation also will vary depending upon the location of the perforation. So if it is a cervical perforation, patient may usually present with neck pain, and this is accompanied by
1 year junior.
dysphagia.
Ullas 1 year junior.
Sorry?
Srikanth is joined, but I think he's on conversation somewhere. Okay.
I'll continue, sir.
Yeah.
Yes, sir. So this can be by dysphagia, hoarseness, dysphonia, or any subcutaneous emphysema. Systemic signs are less common with cervical perforation. And one important feature that is seen is the Hammond's crunch. So, or Hammond's sign. This is basically a bubbling or a crunching sound, which is heard through your stethoscope, and this is synchronous with the heartbeat. This is suggestive of pneumomediastinum, which is absent in cervical perforation but present in intrathoracic perforation. Sudden onset chest pain is a cardinal sign of intrathoracic esophageal perforation, and this pain may be seen radiating to the back or the left shoulder as well. About 20, and as said, the Hammond sign is present here. In 25% of the patients can have a classical macular striate presentation. That is the chest pain, which is accompanied by vomiting and shortness of breath. And in terms of intra-abdominal perforation, patient usually presents with acute onset severe epigastric pain and associated features of peritonitis. And on imaging, we might also be able to visualize free air under the diaphragm. Apart from this, they may be accompanied by either hematemesis or melena. And patients with a perforated esophagus are in significant distress on presentation, and they will have the classical signs of presentation of shock and peritonitis, which will include tachycardia, tachypnea, and possible fever as well. And there may be crepitus, which may be in the neck or chest region, which is suggestive of subcutaneous emphysema. So these are the probable variables that are seen. So which tells us about the mortality percent as well. So if the based on the etiology, if it is spontaneous, it accounts for 36% of the mortality. Iatrogenic being 19 and traumatic being 7. Based on the location, if it is cervical, the mortality in percent is 6%, thoracic is 27, and which is the highest, and abdominal being 21. And time to diagnosis, if it is less than 24 hours, then it is associated with 14% of mortality. And if it is more than 24 hours at the time of diagnosis, then it accounts for 27% of the mortality. In terms of management, firstly, the diagnosis, esophageal perforation, CT of the chest and abdomen is the investigation of choice if the patient has a suspected perforated esophagus. So, because CT is not only highly sensitive in diagnosing this perforation, but it can also assess the damage to surrounding structures in terms of mediastinal, pleural, or pleural contamination. And as these patients can have other differential diagnoses, especially that of an aortic dissection, so exclusion of an alternative diagnosis can also be made by using a CT. And although the plain chest films may show an indirect evidence of esophageal perforation, they are not very sensitive or specific in terms of making the diagnosis. Like classically, if at all evident, then there'll be mediastinal air at the around the site of esophageal perforation, which can be seen. And it is very important to rule out other differential diagnoses because like pneumonia, pleural effusion, myocardial infarction, aortic dissection, and pulmonary embolism. In terms of the initial management, it is essential that we keep the patient NPO, securing large bore IV cannula and ensuring adequate fluid resuscitation. These patients need to be started on broad spectrum antibiotics, which will provide adequate, which should ensure that both aerobic and anaerobic bacteria are covered. This can be done by starting them on antibiotics like piperacillin and tazobactam, and clindamycin or fluoroquinolone such as ciprofloxacin can also be used. And in terms of antifungal coverage, like fluconazole 400 milligrams once a day should be given in selected cases, especially in patients who have had a prior history of long-term hospitalization, or they have received any broad spectrum antibiotic agent prior to perforation because of any reason, and patients on long-term antacid therapy. Apart from this, patients who have received steroids or are on any immunosuppressive therapy, patients with a positive HIV status, and known cases of esophageal candidiasis should also receive antifungal coverage. And ICU monitoring and ensuring hemodynamic stability and volume resuscitation is necessary, and which includes urine output monitoring as well. And going to the definitive management option, the management can either be achieved surgically, endoscopically, or with conservative management. Usually, and most of the endoscopy related esophageal perforations may be treated endoscopically. And three techniques that are commonly used, depending on the size of the perforation, include primary closure with clips or suturing devices, endoscopic stenting, and endoscopic vacuum therapy, that is the EVAC VVT therapy. Uh, when talking about the primary closure method, if there are small iatrogenic esophageal perforation with a healthy surrounding mucosa, which can be approximated with minimal tension, and there is no extraluminal contamination, here we can consider endoscopic primary closure. And it is very important that we rule out extraluminal contamination, because this will contribute to failure of the primary closure and even a possible fistula formation. And in terms of the endoscopic stent placement, uh, they are used only in selected patients who have extensive comorbidities like advanced mediastinal sepsis, large esophageal defects, or if they are not fit to tolerate an extensive surgery. And it is necessary that when we consider taking into account an endoscopic stent placement, it should be done by an experienced clinician. And apart from that, we need to involve a multidisciplinary team as well, which will include a gastroenterologist and a thoracic surgeon. And apart from this, there are 4 factors that are necessary to be identified, because these are considered as risk factors for stent failure. This includes injury, if the injury is in the proximal cervical esophagus, injury that has traversed the GE junction, if the length of the injury is more than 6 centimeters, and if the uh, anastomotic leak associated with a more distal conduit. And the fundamental components that we have to keep in mind is that a diagnostic endoscopy has to be performed so as to localize the perforation to measure the length of the injury. And the stent should the stent should be 4 centimeter longer than the size of the injury, so that there is a 2 centimeter proximal and distal overlap to the perforation. And also, we need to take into account securing an enteral access for further feeding that can be in the form of a peg tube placement. And this should occur before we put the stent. And it should also, we should ensure that minimal insufflation is occurring prior to stenting the perforation, because the stent migration can occur in these cases.
Hello,
And
hello. Just a minute,
yes, sir.
Ines.
Yes, sir.
See, if you practically think, how are you going to put a peg tube in somebody who has esophageal perforation? Because if you pull the peg tube, it may worsen the perforation, right?
So, but it will be at the lower level, no? So, like I thought, because we are
No,
putting it
no.
inferiorly.
See,
Uh,
no. You are pulling the peg tube blindly. After you have gone
uh,
and
yes,
after you put the endoscope in and you put a you transilluminate and then put the guide wire and then you railroad the guide wire with that peg and then you pull it. So as the peg tube goes through the esophagus, it can worsen the tear wherever it is, whether
okay,
it's proximal, mid. So in these kind of situations, you can either do a
also,
nasojejunal tube, or I think put it in the duodenum or into the jejunum, or even you can do a this one
feeding judgment.
feeding jejunostomy or endoscopic jejunostomy.
Yes,
But
sir.
but you can't do a peg in these people.
Okay. Yes, sir. Yes.
Okay.
Yes. Uh, and lastly, coming to the EVAC and endoluminal EVT technique. So this is an evolving technique for management of esophageal injury, and it is generally preferred for smaller defects which can contains defects with intraluminal contamination, in whom patients, especially in patients who cannot tolerate more invasive thoracic procedures. Uh, if it is a non-endoscopic so this is like the basic guidelines that we covered: esophageal perforation and the treatment, the antibiotic coverage, and looking at signs of clinical deterioration, and surgical and endoscopic hybrid repair. Uh, in terms of non-endoscopic related perforations, there are 2 ways. So we categorize patients into 2 ways. Like there'll be a low risk perforation in stable patients, and again, high risk patients. So if there is a low risk perforation in stable patients, then a non-operative management may be considered, provided the patient is stable with early presentation. There's a contained esophageal disruption and minimal contamination in the surrounding spaces. So the presentation should be within 24 hours with stable hemodynamics. And it is for cervical or thoracic perforation on imaging, with the perforation being contained by surrounding tissues, and also, there should be no existing esophageal disease. Here again, the patients are kept on NPO status, proton pump inhibitors, and broad spectrum antibiotics. And enteral supplementation can be started for these patients by securing an either a central line or placing a nasojejunal tube. And as long as the patient is remaining clinically stable, contrast esophagography can be performed every 5 to 7 days. And depending on these results, then there can be resumption of oral intake. However, the threshold for surgery should be kept low here because patients who are showing any evidence of clinical deterioration, like fever, tachycardia, or CT showing extraluminal contamination, surgical or endoscopic intervention should be considered immediately. And in high risk perforation or in patients who are unstable, so here again, surgical technique is we'll consider surgical management. And the preferred surgical technique, so primary repair of the perforated site is the optimal procedure. And here we have to ensure that first the devitalized tissue in the is excised from the perforated site, and the muscular layer should be incised longitudinally along the muscles superior and inferior so as to expose the entire extent of mucosal injury. We should not miss out on any mucosal disruption because this is the most common reason for a persistent leak later on. And again, we will close the mucosa with absorbable interrupted sutures and the muscularis layer with interrupted non-absorbable sutures. And if there has been a delay in diagnosis that is greater than 24 hours, or if at all there is substantial, if at all there is a substantial extraluminal contamination, then here we can do the repair by with the use of a pedicle flap. In these cases, the most common flap that is used is the intercostal muscle flap, and others are like serratus muscle, latissimus dorsi, or diaphragmatic flap. Again, here the surgical management of esophageal perforation. We based on the location also, we can classify it based on whether it is a cervical, thoracic, or abdominal. If it is cervical perforation, if there is surgical exploration and can the defect be visualized, yes, then primary repair is done as explained. And if there is distal obstruction or any intrinsic esophageal disease, then esophagectomy may be considered with diversion or reconstruction. And in terms of the thoracic perforation, here, we have to look for the following, that there is extensive damage which will not allow primary repair to happen. Again, distal obstruction because of an undilated, because of a stricture or a motility disorder. If all of these are absent, then primary repair is concerned. And if not, hemodynamic instability, extraluminal contamination, and time lapse of more than 4 hours, we'll have to consider either esophagectomy with diversion or a hybrid technique, which will involve surgical drainage with endoscopic stenting or T-tube insertion. However, the hybrid procedures are, there is not a lot of significant data which is available so as to support this at present. And again, abdominal repair, abdominal esophageal, in abdominal perforation, primary repair with vascularization tissue coverage should be taken into account. Here, this is an image wherein we are in the first area, we can see that the devitalized tissue is debrided and longitudinal extension is done so as to expose the complete mucosal surface. And after this, the primary repair is done. The closure is performed in 2 layers of interrupted sutures. This is a repair wherein the esophageal perforation is repaired with the help of an intercostal muscle flap. And another one wherein we can use the parietal pleura is used so as to patch up the perforation. And
Einass, just a minute.
yes, sir.
Did you call Dr. Rajshekar Reddy today?
No, sir.
It should have been better, no? Because
Yes,
he's
sir.
the one who does, he deals with esophagus and things like that, perforation and all that. Anyway, students and anybody, any queries or clarification questions so far? Okay, if there isn't anything, continue.
Yes, sir. Uh, going ahead to spontaneous esophageal rupture. Uh, so, uh, Bor uh, Boerhaave syndrome is a spontaneous perforation of the esophagus. This results from a sudden increase in the intraesophageal pressure, which is combined with a negative intrathoracic pressure. And in terms of the epidemiology, the esophageal perforations because of spontaneous rupture are rare, and the incidence is about 3.1 in 10 lakh per year. And as explained, this accounts for 15% of the uh, total esophageal perforations. And it has a male preponderance, males more common than females in a ratio of 5:1, and is associated with a mortality rate of 20 to 40% if the rapid treatment is not given. Uh, the pathogenesis, the rupture results from a very high pressure in the esophagus, which is either precipitated by vomiting, or in less common conditions by coughing or straining. And the perforation is longitudinal and will extend for several centimeters in the posterolateral aspect of the distal intrathoracic esophagus. This is because this is the site of anatomical weakness, and that is why this will occur more commonly in this region. And it usually occurs in patients who have a normal esophagus, but a subset of patients may have underlying esophageal disease such as eosinophilic esophagitis, Barrett's esophagus, or esophageal ulcer. And in terms of the clinical features, the signs and symptoms of presentation, again, they will depend upon the location of the perforation, whether it is cervical, intrathoracic, or intra-abdominal, and the degree of leakage, and also the time duration that has sort of passed since the injury that has occurred. And in most of the cases, vomiting, chest or thoracic pain, fever, dyspnea, abdominal pain, pain radiating to back or uh, is present. Some in 10 to 14% of the cases, hematemesis may be a presentation, and abdominal pain may be seen in 30 to 40% of the cases. And on examination, they may have a subcutaneous emphysema, and the Hammond's crunch may also be heard in these cases. And the routine workup which will be done may reveal leukocytosis, and the thoracic and cervical radiography may suggest signs of esophageal perforation, but again, this will not give a definitive diagnosis. Here in the first, this is like a chest X-ray film which is showing mediastinal or free air around the site of perforation. And again, the second image is a CT image, which is showing like an esophageal perforation with uh, surrounding air around it. And again, apart from this, there is a widening of mediastinum that is seen, and the dotted appearance that the air dots that are we are seeing is the mediastinal air. And preferably CT is the again modality of choice in order to definitively diagnose esophageal perforation. And apart from these, there are some CT findings that can be specific for these, which includes esophageal wall edema, esophageal fluid with or without gas bubbles, mediastinal whitening as shown in this picture, and air fluid levels in the pleural spaces and the retroperitoneum, and also around the lesser sac. Uh, Uh, so the differential diagnosis, like mentioned before, like MI, pancreatitis, peptic ulcer perforation, or aortic aneurysms and dissection needs to be excluded. Even spontaneous pneumothorax is something which has to be excluded. Apart from this, there is the based on the history of forceful retching and epigastric or back pain. This presentation can also be seen in patients with Mallory-Weiss test, but hematemesis is a major clinical manifestation in these conditions. And Mallory-Weiss tear is basically a longitudinal laceration in the distal esophagus. It's not a rupture of the esophagus, which is seen in the Boerhaave syndrome. Management is similar to what was explained prior in terms the way we manage esophageal perforation. And it is in addition to this, Boerhaave syndromes can have underlying esophageal disorders, like mentioned, like eosinophilic esophagitis, Barrett's esophagus, and ulceration. So, and upper endoscopy with esophageal biopsy should be performed to evaluate the esophagus uh, upon as soon as the patient has recovered and based on what is the underlying condition that we are suspecting. Sir, I'll go ahead, sir.
Yeah, yeah. If there is no questions, yeah.
Yes. Going ahead with foreign body ingestion. So, in terms of ingested foreign body ingestion and food impaction are accidental in adults, and it is more common in the children age, like in children less than 5 years of age, and where they are prone to accidentally ingesting coins or small toys. And in adults, in the elderly group, food bolus impaction is the most frequent cause in adults. And apart from this, uh, in adults, food impaction above a pre-existing esophageal condition, like a stricture, esophagitis, is more commonly associated with esophageal obstruction. And most of the 80% of most of the esophageal ingested foreign bodies will pass without any need for intervention. And intervention is required only in 10 to 20% of the patients. And the urgency for endoscopy will depend upon the underlying clinical scenario, the nature of impaction, and in some cases, uh, like endoscopy may be avoided if a radiography is done prior to a procedure. The clinical manifestations will be in terms of an acute onset dysphagia. Other symptoms may be uh, like a foreign body sensation, uh, complaints of choking, refusal to eat, hypersalivation, and retrosternal fullness. There may be regurgitation of undigested food, wheezing rarely, and occasionally blood-stained saliva. Odynophagia may occur, but this will be due to esophageal spasm, and this will also likely be indicative of an underlying infection, ulceration, or perforation. And drooling and inability to swallow liquids is an indication of esophageal obstruction because of the foreign body. And in the uh, but however, in the absence of obstruction or perforation, majority of the patients are asymptomatic once the foreign body has passed. Uh, Complications will include again perforation. So if like explained earlier, cervical perforation can present with neck pain, dysphagia, and dysphonia, odynophagia. And if there is a obstruction, then there may be nausea, vomiting, and cramping pain as well because of the foreign body impaction. Fistula formation, impaction of a foreign body in the esophagus may cause ulceration because of tissue necrosis. And if it is prolonged, this can result in the formation of a fistula. This can be an AO2 esophageal fistula or a tracheo esophageal fistula. So again, if it is at all, it is an AO2 esophageal fistula, then it will be life-threatening bleeding with rapid exsanguination. And tracheoesophageal fistula, patients can present with cough, cyanosis, dysphagia, choking, and vomiting. Uh, it is very important to take a proper history, which includes the type of foreign body that is ingested, the time of ingestion, and the presence and the type of ongoing symptoms. Physical examination should be included. That is a thorough inspection of the oro and hypopharynx, neck, chest, and abdomen, so as to identify patients with esophageal obstruction or perforation. And in imaging, radiographic localization and identification of foreign bodies is essential, and it can either vary based on whether we can consider getting a chest X-ray or a CT done. Uh, and CT scan is performed for evaluation of a few certain specific clinical scenarios, especially where you are suspecting a perforation based on clinical findings. If there is a sharp or pointed foreign body ingestion, and in patients who have given an unclear history of what they have ingested. And again, the approach will be based on the clinical presentation. And for any esophageal foreign body, this will require removal of the esophagus within 48 hours. And this
Removal of
can be
esophagus.
no, sir, a foreign body, esophageal foreign body,
Because you
the
said
foreign
removal
body.
of esophagus, so that will be a bit drastic.
Sorry, sir, foreign body.
Okay, carry. Yeah.
Yes, sir. Uh, so again, this can be either emergent endoscopy or like urgent endoscopy. Emergent endoscopy should be done within preferably 2 hours, but at the latest within 12 hours. And this is indicated in complete esophageal obstruction, either by which is seen by either drooling or inability to handle oral secretions. And if there is disc batteries in the esophagus, sharp or pointed objects in the esophagus. And apart from this, any other foreign body lodged in the esophagus should be retrieved with an urgent endoscopy within 24 hours of ingestion of the foreign body. This is because the risk of complications will increase with the time. And foreign body in the stomach or the proximal duodenum, most of these bodies that with foreign bodies that enter the stomach will pass on in 4 to 6 days. Objects more than 2 to 2.5 centimeter may not pass through the pylorus or the IC valve. And again, at objects longer than 5 to 6 centimeter may have a propensity to get obstructed in the duodenum. So again, early upper endoscopy is indicated in these patients. Like if it is a sharp object in the stomach, objects of more than 5 centimeter, and magnets, if at all, within endoscopic reach. And uh, upper endoscopy, like explained, blunt objects in stomach which are more than 2 centimeters, or disc batteries and cylindrical batteries which are in the stomach for more than 24 hours are also should be considered to for endoscopic retrieval. And apart from this, so if the diameter is less than 2.5 centimeter, length is less than 5 centimeter, and asymptomatic patients who have consumed blunt objects, these can be managed conservatively. And so they should undergo radiographic monitoring, and they can resume normal diet. Apart from this, osmotic laxatives may be used, like polyethylene glycol, because this will dilute the intestinal content, and after this facilitate and help in the passing of the foreign bodies in stool. And patients who have failed this expectant management will either because of the non-progression of foreign body through the stomach in 3 to 4 weeks, or if they are remaining in the distal duodenum for more than 1 week, or if they develop symptoms of abdominal pain, then we have to consider endoscopic or surgical management. And foreign bodies which are distal to the ligament of teeth, these cannot be retrieved endoscopically. So again, we have to keep radiological follow-up has to be done so as to uh, assess the object's passage through the GI tract. And if there are any metallic objects, they are more prone to causing perforation and sometimes can even cause foreign body appendicitis. So in these cases, we have to consider surgical management as an option. And another option is deep small bowel enteroscopy, which can be considered as an alternative to surgeries for the management of this. And for the management of objects beyond the ligament of Treats. And there are certain specific techniques and considerations that are based on the type of uh, product, like whatever is ingested. So if it is food bolus, we can administer glucagon, that is 1 milligram IV, which can be attempted. And glucagon may relax the esophagus, which can allow the food bolus to pass. Apart from this, it also induces retching, which may help in dislodging the food bolus. And on endoscopic techniques, they can be removed using grasping device, either in piecemeal or en bloc removal, and or it can be gently pushed into the stomach using endoscope. And again, this has to be performed by a expert physician, so as to make sure that you're not excessively pushing it into the stomach using the endoscope. And so, if at all an esophageal stricture or ring is identified at the same time, then dilatation should be performed during the same session, provided there is no significant mucosal inflammation that is noted. And budesonide is considered as a medical rescue therapy. So this has shown to help in resolution of esophageal food impaction without any endoscopic intervention. But however, this is still under trial. Uh, if there are blunt objects that are ingested, they can again be retrieved with the help of like a forceps, like a rat tooth or alligator forceps, or a snare or a retrieval net. And as explained, we have to keep into account the diameter 2.5 centimeter and 5 centimeter. Longer objects should be retrieved, and these can be grasped with a snare or a basket, and they can be drawn into usually they come with a long overtube in which you can sort of withdraw the long object, and then as an entire apparatus, you can remove this foreign body. And sharp objects, which could be fish bones or paper clips, needles, this in the esophagus is a medical emergency. So endoscopic management may be difficult in these cases, especially if the foreign body pierces the esophageal wall. So if surgical treatment may be required in these cases, and it is especially warranted if there is associated abscess formation with these foreign bodies, or there are signs of esophageal perforation at the time of presentation itself. And the last is disc batteries. So disc batteries in the esophagus, first and foremost, we have to ensure that there is mucosal protection. So studies say that if we administer sucralfate within the first 12 hours after battery ingestion, then this will help in protection of the mucosa from caustic injury while we are awaiting endoscopy. Uh, Endoscopic removal is attempted, and batteries less than 15 are very easily that can retrieve. And also we have to make sure that contact of the flat esophageal while retrieval, that the flat esophageal wall with both the poles of battery should not happen, because this can conduct electricity and result in liquefactive necrosis and perforation. And in the battery, most of the disc batteries that are in the stomach, they will pass without any consequence. However, we require serial radiographic monitoring every 3 to 4 days, and 85% of these cases will pass within the next 72 hours. And For magnets, all magnets that are within endoscopic reach should be removed if possible. And ingested magnets may cause severe gastrointestinal injury because of the basically the attractive forces in between the magnets that are ingested. And this can result in fistula formation, perforation, obstruction, or volvulus, and even peritonitis. So it is essential that we emergent removal either surgically or endoscopically needs to be considered.
What is the mechanism of action of glucagon?
Uh, so
Hello?
it is basically causing muscle relaxation, sir. So like whenever
ನಾನು
we add,
ಇವಾಗ ಕ್ಲಾಸಲ್ಲಿ ಇದ್ದೀನಿ ಇನ್ನೊಂದು 20-30 minutes ಬಿಟ್ಟು ಮಾಡ್ತೀರಾ ಫೋನು? ಓಕೆ ಓಕೆ.
like usually we administer 1 milligram IV and this will relax the esophagus. Apart from this, it also causes retching, sir. Like it induces retching. So the food bolus may be dislodged.
Retching may perforate the esophagus also, no?
Uh, yes, sir. Like that is like a secondary mechanism, sir. Primary is the relaxation, which
What is the percentage of success?
So that I'm not sure of that, sir. Like primarily we try for endoscopic retrieval, but in some cases we can, and it is only done when you are suspecting a food bolus, not if there is any magnet or sharp object which is
I am
ingested,
asking
sir.
for footballers only.
Yes, I am not sure about this, sir.
Okay.
By and large, you don't, if endoscopy is available, which probably it is available everywhere now, you don't do all these things. If only if it is not available, if it is in distance, then you might suggest doing that step. Think that, but I don't really know the.
If endoscopy cannot retrieve, I don't think glucagon can retrieve.
ಅದೇ ಅಲ್ಲ ಎಂಡೋಸ್ಕೋಪಿ ಅವೈಲಬಲ್ ಇಲ್ಲ ಅಂದ್ರೆ ಈಗ ಯಾವುದೋ ಊರಲ್ಲಿ ಪೇಷಂಟ್ ಇಸ್ ಬಿಫೋರ್ ದ ಟ್ರಾನ್ಸ್ಪೋರ್ಟಿಂಗ್ ಮೇ ಬಿ ಸಂಬಡಿ ವಿಲ್ ಅಡ್ವೈಸ್ ಇದೊಂದು ಇಂಜೆಕ್ಷನ್ ಕೊಡಿ ಅಂತ ಬಟ್ even glucagon may not be available in those places also, so it's a bit difficult. I think endoscopy is a treatment of choice.
Choice for most of them.
Yeah. Okay, carry on.
Yes, sir. Going to leiomyoma. So leiomyoma is a benign tumor of the smooth muscle, which is arising from the muscularis mucosa of the esophagus. And this is the most common benign tumor of esophagus, which accounts for 70 to 80% of all benign esophageal tumors. And it is the second most common after carcinoma overall. This is usually solitary, rarely multiple, and it is for the giant leiomyoma. There can be a characterization or a type that is giant leiomyoma, which is defined as more than 5 centimeter tumor size. And malignant transformation is very rare in a setting of leiomyoma. Apart from this, the anatomical distribution, lower 1/3 is the
You
most
should
common.
give percentage, not rare, very rare.
Sir, it is actually around 0.5 to 1%, sir, of transformation, sir.
And Ainas, is
Yes, sir.
is this different from GIST? Because I think leiomyoma, the
Don't think it has got anything peculiar.
terminology has been given up now. So is it different from GIST or is it the same as GIST?
Is it included in GIST?
Sir, gist is no, sir. It is different, sir. Like this is from the smooth muscles. Like it is like the pacemaker cells are where the gist is arising from, sir. And and most commonly it is occurring in the stomach. Otherwise, leiomyoma is very pertinent to esophagus and rarely the stomach. And gist is there has
Is it a separate entity from GIST?
It is, sir. It is because gist can turn malignant, sir. It is high potential for malignancy in comparison to leiomyoma, which is benign.
Depends on the grade.
Yes, sir. Grade and immunohistochemistry, sir.
Yeah.
Both are different in gist and leiomyoma, sir.
Okay, carry on.
So here in immunohistochemistry studies are not required.
Yes, sir. So in terms of distribution, it is most common in lower one third, 60 to 65%, middle one third accounting for 25 to 30%, and in the upper one third, 5 to 10%. And apart from this, they also have a growth pattern. Based on this, they are either classified into intramural, extraesophageal, intraluminal, and annular types. The peak age of occurrence is between 30 to 60 years, with a male to female ratio of 2:1. And they are usually asymptomatic. Nearly 60% of these cases are asymptomatic. And sometimes they, if they do come, they'll come with dysphagia, which is the most common symptom for solids. And there can be retrosternal discomfort and dull aching chest pain. Epigastric pain, nausea, or heartburn is less common. And weight loss is very rare unless there is a suspected potential of it being a malignancy. And tumors less than 3 centimeter are almost invariably asymptomatic. Tumors between 3 to 5 centimeter are symptomatic, and giant gliomyomas are usually symptomatic. And if at all the patient comes with complaints of acute dysphagia, then we have to suspect an impaction at the site or torsion. And here, the dysphagia is intermittent, slow, progressive, and more for solid, unlike in carcinomas. And this is rarely associated with any weight loss or any nutritional compromise. And if at all it is a large tumor, then only it is associated with very rare tracheal compression leading to respiratory symptoms. Uh, Here, the on grossing, it is well encapsulated, firm, pearly white tumor, as seen in this image, arising from the muscularis propria, and the cut surface, as seen here, will have a characteristic whorled pattern, and there will be no evidence of hemorrhage, necrosis, or cavitation that can be seen. And on microscopy, there will be interlaced bundles of spindle-shaped smooth muscle cells, and there'll be scanty fibrous stroma, and there'll be no associated nuclear pleomorphism or necrosis. And when IHC is done, SMA, Desmin, and will show positivity. Apart from that, CD17 and Ki67 index will be low. Again, on investigations, upper GI endoscopy, usually an incidental finding. Here, the submucosal bulge is intact and mobile over the overlying mucosa. So this is typically the hammock sign. And we don't do biopsy if you're suspecting a leiomyoma, because it might disrupt the capsule. So if at all a further surgical intervention is planned, then it complicates this. Endoscopic ultrasound is the gold standard, wherein you will be seeing a hypoechoic mass arising from the fourth layer, and smooth, well-defined borders with no invasion. CT thorax will tell us about the exact size, location, and relation to adjacent structures. And primarily, there will be no invasion of adjacent structures. And this is essential if you are doing a preoperative plan for a large or giant tumor of more than 5 centimeter. And MRI is done, or a PET CT is done usually when the CT is inconclusive or we are suspecting a malignant potential. And on PET CT, again, there'll be a lower absent FDG uptake. In contrast to this, GIST will show a higher uptake. These are a few images. Here we can see a soft tissue tumor that is arising from the wall of esophagus, and this is displacing the esophagus, causing narrowing of its lumen, but there is no invasion. In the second image, again, an oval mass that can be seen from the lower esophagus displacing the esophagus and narrowing the lumen, but no signs of invasion are noted. Uh, in terms of management, once there is a confirmed esophageal leiomyoma, if it is symptomatic, size more than 3 centimeter or diagnostic doubt, then you will consider surgical treatment in the form of enucleation. So extramucosal enucleation is the standard, wherein VATS or VATS is preferred if it is less than 8 centimeter. If it is giant or a complex cyst, then open thoracotomy may also be done. And if at all enucleation is not feasible in rare scenarios, esophagectomy is considered. However, if all of these signs that are mentioned, like no symptoms or size less than 3 centimeter, then conservative management and surveillance is more than enough with endoscopy and EUS every 12 months. And we operate only if there is growth, if there is new symptoms, or if the patient has to be it's the patient preference if patient wants it to be excised, and the red flag symptoms of malignancy have to be counseled to the patient. And in terms of complications, intraoperative complications like mucosal perforation, hemorrhage, injury to the thoracic duct may be common. As we are using a VATS approach here for excision, recurrent laryngeal nerve injury may also be a complication. This is intraoperatively, and postoperatively, esophageal fistula, leak, mediastinitis, pleural effusion, and rarely stricture and dysmotility may occur. Recurrence rate is 2 to 3% in cases of incomplete excision, and this is more if there is a piecemeal excision or a fragmented enucleation. And again, follow up with OGD at 6 months, then annually for 2 years needs to be done. And it has an excellent cure rate of more than 95%, and the potential for formation of a leiomyosarcoma is extremely rare. So overall, the
Why should you
prognosis
do
of this
repeat
is
endoscopy if the biopsy comes as benign?
no, sir. If at all we are suspicious that if there is an incomplete excision, sir.
Even if it is
So
incomplete, why should you do endoscopy?
because of recurrence, sir.
Why should it recur leiomyoma?
Sir, if there is an incomplete excision, like the
Even if
enucleation
it recurs, patient is asymptomatic. Why should we do?
so for surveillance purposes, sir.
No, but
And it is
you said malignant potential and transformation is very rare, no?
yes, sir. This is in if at all we have excised it, sir. Like we are
Correct.
only excising if the diameter is more and patient is symptomatic, sir. So only in those cases we are doing a follow-up.
Okay.
Okay.
Uh,
Because in a repeat endoscopy may cause perforation. Already the wall will be weaker.
yes, sir.
Be very careful with these things. Okay. Is that all? Finished?
Yes, sir.
Okay.
Like all the benign disorders are completed
Yeah.
with this, sir.
Okay. Now students, anybody wants to comment on the class, the slides, knowledge, the information? Likith, you've been silent. Likith, are you there?
Yes, sir.
Comments, questions?
Nice class, sir. Madam presented well.
No,
Slides are also good.
no questions.
No, no, sir.
Okay. Karthik,
Sir, it was a very nice class, sir. Very attractive class. The slides were very good.
Sanya,
So nice class, very well explained. Everything in detail, sir. No questions from my side.
Srikanth,
Good presentation. What is the difference between Boerhaave syndrome and Malaria's pathology?
So Boerhaave's is like this perforation, sir. And Mallory Weiss is the tear, sir, like a longitudinal tear.
Yeah,
It is
make
not
also
as
very good presentation.
Okay, I think if there are no questions, Ainas, you presented very well. I think this, to say it is quite a boring topic, but you have covered it very well and you have explained all of the.
Because we have not, because most of us will not see this case borrowing lifetime.
Yeah. So I think it is mainly for theory, but you may encounter this occasionally.
Yeah,
And
short notes you will
you
get in
should
exam.
know. You should know. Okay, good. I think you did a very good job. Well done. Good night if there are no questions. Thank you, everybody.
Thank you.
Thank you, sir.